for any graft to be stable, the footprint or the diameter for a circular one or a quadrangle, the footprint has to be significantly wider and larger than the height. This is the best biomechanical situation. Say for that matter, you have a nice broad diameter of a cage and a very short length, that's the best. But every time it's not possible, especially if you are doing one or more level corpectomy, your graft footprint will be smaller and your height will be larger. So inherently it's an unstable situation, and therefore the neutralization instrumentation that you use has an extremely important role. The neutralization instrumentation is not to be done cursorily. In fact, it is to be done far more seriously than the putting in a cage or even iliac bone graft, trichal cortical graft, whatever. So just remember that. Okay. Now, I have been given a topic about how to deal with unhappy patients if a patient comes to you. Well, creating an unhappy patient is the most useful or most common hobby of all of us. I call it a hobby. अगर थोड़े दिन अच्छा काम करने के बाद कंटाला आया तो एक अनहैप्पी क्रिएट करो. And I want to make another statement here. We say this is community practice. That means a Maharashtrian fellow going to Maharashtrian doctor, a Gujarati patient going to Gujarati. We commonly call that as a community practice. But spine surgery overall is a community practice. One patient belongs to multiple spine specialists. In other words, patients will keep on moving, irrespective of whether they have a complication or not. Even if they have a fairly good results, they'll still go and have second opinion with some doubts and something. So that patient is to be considered as unhappy simply because he has come to ask you. Patients generally come and tell you, my surgery has failed. Now you have to fight to understand that was it really, truly bad enough of a spine surgery problem, or it's a general problem. And I'll tell you what I mean by general problem. While good recovery of the spinal syndrome is the reason why patient comes to us. I have so and so problem, pain point of view, function point of view, neurology point of view, and give me good relief out of that. But it's not all that. Patients also seeking the good care A to Z right from the point where patient has seen the receptionist to seek an appointment. Right from there to the discharge and follow-up, patient wants a good care, and that's the experience that patient wants to. If these other elements are also bad, if they are unsatisfactory, in spite of you doing good surgery, by all means good surgery and all good results, patient still will be unhappy, still be unsatisfied, and you will have to really work it out that way. What is it? Why are you unhappy? You'll have to work it out. Don't only search X-rays, don't only search MRIs, try to find out why is the patient really unhappy. Also remember patient's mindset. All of you know that spine surgery is a badnaam surgery. Most come to us with the presumption that ये surgery तो fail होने वाला है. Majority of them, in fact, they are reluctant to undergo surgery because somebody or other has already told them, ये surgery कभी success नहीं होता है. So their mind is primed up to think the smallest of a tingling numbness, residual left behind, is also interpreted by them as a failed surgery. Over 80% patients are reluctant to undergo surgery. Eventually, when they get ready to go through surgery, they entrust themselves in our hands against their own will and against their extended family's will, who are telling them, क्यों surgery कर रहा है, क्यों surgery कर रहा है. So basically, patient has come to us who is unwilling. Also remember one thing, that for me, doing surgery or a surgical event is a routine thing. Surgery with some pain remaining behind, some tingling remaining behind, some difficulties, etc. For me, it's a routine thing. For a patient, it's a once of a lifetime experience, and this is where patient will concentrate his attention and will copy. Most patients around the time of surgery, especially any major surgery, the cardiac surgery, bypass surgery, spine surgery, malignancy surgery, these are the people who are feeling terribly vulnerable. They have no control over that unknown thing. It's called a surgery. Whatever is his surgery, spine surgery. They have overwhelming anxiety. This anxiety not only is there pre-operatively, even when everything goes through well, the anxiety persists and continues thereafter for a long time. In some people, even further on. So these are the people who often misinterpret the normal post-op syndrome as a complication. Now this is a large group of patients who come to us. All that looking for from you is a reassurance. That is something we fail to give them. The surgeon, if I have operated upon a patient has residual symptoms, I fail to explain to him properly. I fail to pacify him. I fail to convince him. And then that patient my patient goes to Sudhir Srivastava. My patient goes to Sanjeev. That they need to be reassurance. These patients, if they are not convinced about what you are talking, they will behave erratically. They will be angry. They will be upset. Their behavior very often is a challenging behavior, as far as I am concerned. To him, मेरा केस खराब हो गया है, मुझे गुस्सा नहीं आएगा क्या? For him it's a natural thing, but for us it's a unnatural thing. So we judge him from that point of view and we think it's unreasonable. Also, most of us surgeons, it doesn't mean that physicians don't, most of us don't want to believe, don't want to hear, and don't want to talk and accept that complications can occur in our hand. Somewhere the subconscious ego comes in our way. And we can be incompetent. And more than that, we can be unfair to the patient. We don't believe that. No, ऐसे कैसे मैं तो सब कुछ किया हूँ, मैं उसके साथ अच्छी बात किया उसके साथ. This patient, he was post-operative pain or function difficulty or is suffering, feels helpless. Then he tries to contact me. Either he contacts me or my registrar or my fellow or my assistants or clinical assistants or my receptionist or my counselor. And when those agencies also either don't give attention, they don't give him relief, they don't give him something, he's upset. Then he feels that injustice has been done to me. Then he starts distrusting not only me but my whole setup. Then he talks anything. When that happens, my registrar says, "Sir, वो कुछ भी बकता है, कुछ भी बोल रहा है." So the mutual distrust starts there and the whole thing eventually escalates. I've used word problems here, not the complication. Complication is something which will happen as an episode during surgery or peri-surgery, but the problem is something which will continue for a long time to come. All of you know, and you have been told by n number of speakers before, that most common reason for unhappiness is a poor communication with the patient. Yes, I just want to reiterate, therefore I put it here. You also have to remember one thing, like in some Western countries, it's a regular thing or regular tradition. They throw statistics on somebody's face, both preoperatively and even postoperatively. Okay, 16% patients always have problem. So you are one of those 16%. What's the big deal? You throw it preoperatively, you bombard so much of statistics on them that they don't understand it. Either they run away or they undergo surgery without understanding their statistics. And when he has a pain, you are again trying to throw that statistics to him. Look here, I had told you, 16% chance hai ye hone ka. That patient is concerned, the statistics does not mean anything. For him, it's 100% problem. He says, I have 100% problem. You don't tell me about statistics. It's about that human being, the way he is treated, the way he is made to feel, and how they perceive their value in the whole medical care system. And all of you will agree with me that medical care system is in fact progressively becoming depersonalized. What rapport my previous generation had, my generation it was little less. Next generation was still less. And now we do find that the communication, the connection, the relationship between patients and doctors, I'm not saying above the board, but percentage is decidedly going down. If something happens, the patient just cannot contact me for 2 weeks, 3 weeks. Kuch gadbad hai, he cannot contact. He has to go through the channel, the registrar, the receptionist, etc. In the sense, these patients are unhappy overall due to that. Well, friends, there are grades of unhappiness. Somebody can be just unsatisfied. If something going beyond, they are upset when the mechanisms don't work, and when mechanisms create irritation, they are furious, they are even vengeful. So vengeful or khunnas wala patient is not a natural creation. Very often it is created by us. And we must be careful to avoid happening to us. 96%, I'm talking about some statistics now, 96% unhappy patients do not complain. वो चुप बैठ जा रहे हैं, अरे वो तो पीछे रहने वाला है दर्द थोड़ा तुम्हारा. So he keeps quiet, goes away. And most of them simply go away, they go elsewhere, see somebody else, or they keep talking to 10 other people about the negative experience. In other words, you are not directly affected, but you are indirectly affected. And worse than that, the whole spine surgery as a useful treatment is affected, gets disrepute. Remember, every patient who complains of complication is not a potential troublemaker. He has genuinely come to you voicing that I am not well. Sir, I have problem. Sir, I have difficulty. He has genuinely come to you for a help. We, by our behavior, produce troublemakers out of them. The first most important thing is, and now I'm not talking about me as a primary surgeon, I'm talking me as a second opinion clinician. First thing is, don't hide the problem. Because today or tomorrow, the problem, even if it's operated by your own son or your own father has done surgery, if the patient has a problem, don't hide it. You can soften the news by telling him. For example, if a wrong level surgery has been operated upon, say L4-5 needed decompression, L3-4 has been done. What do I tell the patient? ये सर्जरी के टाइम मुझे लगता है वो ऊपर से चालू किए और वो काफ़ी अच्छा हो गया है. नीचे की लेवल पे थोड़ा सा टाइटनेस अभी भी बाकी है. What have I done? Have I avoided telling him that L4-5 is not decompressed? I have told him, but I have softened it. I said, वो एरिया थोड़ा टाइट लग रहा है अभी भी. देखते हैं क्या करना है. So I am trying to soften that news. Screws, implants cutting out, screws giving trouble. Can I hide to a patient that if he has developed post-anesthesia, complete foot drop on one side, and he comes to me, can I hide the fact that he has been injured, he has been damaged? It may be shortly lasting, it may recover in a few days' time, or it may never recover. But can I hide that from him? I can never. There are many things which I can. In fact, I insist, I say that please tell the patient, क्या हुआ है, कैसे हुआ. So the patients immediately ask, ऐसे कैसे हुआ? I say, yes, these are the problems which can occur, they're quite common. And मेरे हाथों भी ऐसे हुए हैं कई केस, मेरे हाथों से भी पेशेंट को डिफिकल्टी आई है. When you say that it is common and it can come in my hand, to whom you have come as a senior person, experienced person for an opinion, if I say this openly, they have some amount of consolation available. They are not excuse the previous surgeon, but at least they are less furious. So you got to tell them that these are things. Now another thing is very important, which I have been following, and I would advise you very strongly to follow this. I don't like to use the word complication. I use the word problem. First thing, I don't blame the previous surgeon. I never ever blame the previous surgeon. And I say that post-op problems are common. And when I'm talking further, I don't use the words which upset the patient. Like we say, complication हो गया है, mistake हो गया है, goof up हो गया, गलती हो गया है, वो गलत किया है, राड़ा किया है, वो तुम्हारा केस फायर हो गया, बॉचअप हो गया है. I never ever use these words. I only say post-op problems, post-op problem, post-op problem. I only use these words, post-op problems, so that you are not feeding the words. These are the words, these are inciting words. You might say it casually, but somebody who was not wanting to do litigation on the previous surgeon now may want to start litigation simply because you said rada kiya hai. The moment I say that, the patient would want to sue somebody else. So don't use those words. Give full picture in simple words. Very often the previous surgeon has not told them sincerely. So using preoperative reports themselves, I explain to them, hey, look here, you had a complication or a problem at 4-5, but your upper vertebra are already worn out. और बहुत सारे घिस गए हैं, आपको बहुत सारा ऑस्टियोपोरोसिस है, और आपके ऑपरेशन के पहले के एक्सरे में ये दिखता है, नीचे भी टाइटनेस है, वो भी दिखता है. तो ऑपरेशन तो एक जगह किया है, अभी शायद आपका पेन ऊपर के सेगमेंट से आता होगा. Am I lying? No, I'm not lying. What have I done? I have used these old original X-rays and MRIs. I've used old original findings. If EMG nerve conduction studies have been done preoperatively, I use them and explain to the patient, look here, this was something probably expected. Oh, उन्होंने क्यों नहीं बोला? I said, they must have thought कि आप समझ जाएंगे या शायद आपके ध्यान में नहीं रहा होगा. ऐसे कैसे बोल रहे, आप उनकी साइड ले रहे? नहीं, मैं साइड नहीं ले रहा हूँ, उन्होंने शायद कहा होगा. तो फिर ऐसा कैसा किया उन्होंने अंदर, ये मुझे तो बताना मुश्किल है. वो अंदर सर्कमस्टेंसेस में अंदर क्या एग्जैक्टली निकला, एक्सरे पर तो ऐसा दिखता है, अंदर क्या निकला, उनको क्या डिफ़िकल्टी आई, क्या क्या सिचुएशन थी, उसके मुताबिक उन्होंने क्या क्या डिसीजन लिया, ये मुझे बताना मुश्किल है. वो ही बता सकेंगे आपको क्या. आप एक काम करिए, मुझे लगता है आप फिर से वापस उनके पास जाइए, उनसे बात करिए, उनको कहिए कि मुझे ज़रा एक्सप्लेन करिए अच्छी तरह से क्या हुआ है. Now, if this gentleman, previous surgeon, explained to them properly, he knows that patient has gone to Dr. Ingalhalikar and patient has come back. So now I've got to do things differently than he did when he came with complaints to me. Probably he does. There are times on which I have picked up a phone and called the previous operating surgeon. If I feel the patient is furious and is likely to be vengeful, I have picked up phone and talked to the previous surgeon. देखो भाई, तुम्हारा ऐसा ऐसा पेशेंट मेरे पास आया था और वो काफ़ी गुस्से में है. This is what I have told him. I do that. In case I feel that the litigations or something is already started, किसी ने already complain किया है, then I don't ring up that patient, that surgeon directly. I will not ring up Sudhir directly. I'll tell Sanjay, Sudhir को बोलो मुझे फ़ोन करने को, और सुधीर को बोलो उनका एक पेशेंट आया था, नाम उसका ऐसा है, काफ़ी गुस्से में है. So Sudhir gets a message but not from my phone, or Sudhir doesn't read my message. So these are the ways we can sort of soften the impact on the patient, on the thing, and we can really help. Number one is, lot of these patients will require revision surgery. Again, I try not to use revision as a word. I like to use word repeat surgery. ऐसे तुमको फिर से करना पड़ेगा. ये वो क्या रिपेयर करना है क्या? नहीं, फिर से करना है. If you use the revision is something which was badly done, therefore now I am trying to improve upon it. ऐसे थोड़ा meaning जाता है. So I use word repeat surgery. आपकी सर्जरी फिर से एक बार करनी चाहिए. थोड़ा थोड़ा कुछ बाकी रह गया वो पूरा करेंगे. Again, remember one thing, try not to sell the surgery to them. Explain to them, let them think, maybe your opinions, doesn't matter. But try to see that thing. Complications, the word which I don't like, I use the word problem. Problems are going to happen in everybody's hand. Even today at my seniority, my experience, I do create problems. I do. I might do wrong level surgery. I might do inadequate surgery. I might do wrong implant surgery. I'll still do it. But they are all problems. And because it's going to happen to everybody's place, the patient must be taught by the second surgeon to look at the whole thing in a correct, unbiased perspective. It's difficult for a patient to go unbiased because patient is suffering. Therefore, he will not be unbiased. He would be thinking from his point of view, his suffering point of view. Sometimes taking it for granted कि पहले सर्जन ने गड़बड़ किया ही है. You got to see what best you can do for these people. I have found that very often the residual difficulties patients have, these are the patients who eventually accept that thing. Or somebody who has a worse situation, complete cut off of the root, and immediately instantaneous post-op drop. I've got to tell the patient, look here, ये हुआ है, ये रिपेयर करके भी खास फर्क पड़ने वाला नहीं है, आपको ये एक्सेप्ट करना है. In the beginning he will be furious, he will even shout at me as a advisor. ऐसे कैसे बोल सकते हैं, आप कुछ ट्राई भी नहीं किए, कुछ कोशिश भी नहीं करने को बोल रहे. ऐसे नहीं, मुझे जो दिख रहा है कहना मेरा काम है. I have to honestly tell you what I see. But these are the people who, because you have told them correctly, squarely, they would accept. The acceptance part also is to be taught to them by making them look at the whole affair in a little different way.